Hello friends, today I'm going to explain you here about ATLS protocol where B component. First is airway, second is B is breathing assessment. So breathing assessment begins with inspection of interior neck and chest, looking for external injury or marks, expanding hematomas, abnormal chest movements, distended neck veins, position of trachea, any air bubbling out of the neck or chest, air leak and external hemorrhage. So what does it mean? Airway you secured. After that, breathing component will see. So you have to observe the neck. Is there any abrasion? Is there any wound? Is there any active bleed on neck? And chest, see chest movement, or is there any flail chest, rib fractures? You have to see, or air, any air leak means from chest like pneumothorax open. Okay, chest movement you have to identify, neck veins you have to see, position of trachea, okay, or any active bleed from chest or neck. Auscultation of chest or for breath sounds might reveal decreased breath sound in case of pneumothorax or absent breath sound in case of tension pneumothorax, that is emergency. Muffled heart sound or additional respiratory or cardiac sounds like stridors and murmurs you can see on auscultation. But in a busy and noisy emergency department, the auscultatory findings might not be reliable. Okay, so pain and surgical emphysema are the most common palpatory findings indicative of bony injury or injury to hollow structures such as lung, trachea, esophagus, respectively. So, guys, maybe auscultatory findings are not reliable. You have to do palpation. On palpation, you feel surgical emphysema. Okay, and you can also find some bony injuries on palpation, okay, or lung or trachea or esophagus respectively structures. The chest cavity can conceal approximately 3 liters of blood in each hemothorax without any external signs, and therefore relying only the clinical findings can be catastrophic. Okay, breathing agents such as chest x-ray and e-fast examination can aid in further management. So guys, what happened in one massive hemothorax? 1500 blood, another side 1500 blood, so total 300 3 liter blood. Okay, so 3000 ml approximately. You have to go through x-ray or e-fast examination for seeing further. uh, Now, approximately 85 to 90% of chest injuries can be managed non-operatively or with the help of intercostal drainage. Only 10-15% chest injury patients require operative management. Okay. So, what is the criteria of massive hemothorax? I explained in my previous videos. When there is a 1500 ml blood, you insert ICD comes immediately. Then you have to do thoracostomy. Okay, or 200 ml blood continuous from 2 to 4 hours in ICD drain, so you have to do thoracostomy if patient is unstable, or if patient is unstable in spite of ICD, you have to do thoracostomy. Chest injuries have been classified into life threatening and potentially life threatening injuries in ATLS 10th edition. These life threatening injuries are to be identified and managed during primary survey. Most of the injuries can be stabilized in the emergency department with the help of intercostal drainage tube. In patient with high likelihood of chest injury presenting in extremes, even presumptive placement of implantable cardioverter defibrillator also is acceptable and can help in diagnosis of management. The preferred site of needle decompression in tension pneumothorax is second intercostal space, mid-clavicular line in pediatric patients. But for adults, fourth and fifth intercostal space between the anterior and mid-axillary line, same as triangle of safety in adults. Why fourth and fifth intercostal space in adults? Because second intercostal space have very huge muscle mass. That's why fourth and fifth is considered in case of adults. Earlier, needle decompression was recommended in second intercostal space in all, but because of the increased chest wall thickness in adults, the needle decompression is unsuccessful and variable in one third of times, and hence ATLS recommend fourth, fifth intercostal space in adults. Now, life threatening injuries and potentially life threatening. Uh, Life threatening injuries immediately identified and managed during primary survey like airway obstruction and tracheobronchial injuries. Whereas breathing, you find tension pneumothorax, open pneumothorax, massive pneumothorax. In circulation, massive pneumothorax, cardiac tamponade, and traumatic circulatory arrest. Tension pneumothorax, do needle decompression and placement of ICD. Open pneumothorax, three-way bandage, or you can close the wound and put ICD. Massive pneumothorax, put ICD. And massive cardiac tamponade, do pericardiocentesis, and after that, cardiac repair is required. Traumatic cardiac circulatory arrest and potentially life-threatening injuries to be identified, managed during secondary survey. Like simple pneumothorax, hemothorax, flail chest, pulmonary contusion, blunt cardiac injuries, traumatic aortic disruption, traumatic diaphragmatic injury, and blunt esophageal injuries. So, guys, I hope breathing primary survey B is done. Okay. I hope you understand what you are going to see in breathing part. So guys, thank you for watching this video. If you like this video, put like on it. If somebody is new on my channel, please subscribe this channel for more such videos and watch ATLS update and trauma surgery. Thank you.